So we're going to talk about the ICMS lab, clinical guidelines, and Reimplant registry. So thought this was kind of interesting. This is how genetics works. So I thought that was an interesting thing. So for those of you that don't know, just this year, we got together a group of physicians, research scientists, regulatory attorneys who were interested in this area of adult stem cells, specifically autologous adult stem cells, and started to put together a number of different guidelines. Oops, somehow I got to go back there. So lab guidelines, practice guidelines, treatment registry, to try to get to safe adult stem cell therapy. These are professional guidelines that have been put together. We have everything done, including the treatment registry now, and these will go through a lot of different iterations through the years, but I'd like to introduce these to you. Our focus was to get patients to start receiving treatments now rather than 10 or 15 years from now. And my initial thought my initial exposure to this was, in fact, with the Stem Cell Pioneer group that Henry brought up. These were a bunch of very dedicated, but usually terminally ill patients who were reading about all this very neat stem cell stuff, but unable to get access really to any of it. Most of these people will have perished before we ever get around to seeing FDA-approved biologic drugs. So they had a very acute interest in all of this, and they were very much involved in the motivation of putting all this together. One of the ways or the strategies that we took was to try to limit the type of cells, limit changes to the cells. Henry's just talked to you about a very simple process for isolating BLSCs to try to be able to have patients utilize stem cell therapy sooner rather than later. We looked at types of stem cells that were out there. Obviously, Henry brought up iPS cells. For those of you who haven't heard about this, you take an adult somatic skin cell, for instance, you expose it to various chemicals or processes, you revert it back to an embryonic-like cell, and that's an iPS cell. Obviously, you've heard a lot about embryonic stem cells. They've been all over the news for a very long time. Cord blood or fetal stem cells, another stem cell type that's out there. Someone else's adult stem cells. There are multiple drug candidates going through the pipeline right now that are someone else's stem cells in a vial. And your own stem cells, which is really what we're talking about here at this conference. So we had to make the decision that iPS cells were far too risky for clinical use at this point for all the reasons Henry just discussed. Embryonic stem cells, again, for the same reasons. The cord or fetal stem cells, again, for very similar reasons and rationales. And as I'll talk about later in my main talk, someone else's adult stem cells were in that same category. Your own stem cells, though, did reduce those risks, so they would be an appropriate candidate for early use. So if we're looking at all those different candidates, your own stem cells would be likely the safest one with the least possible side effects. Now, even with your own adult stem cells, you can make changes to them. You can do lots of things to stem cells. You can insert genes. Obviously, that's been talked about in the literature. There's some research going on. You can do long-term cultures. Basically, you can immortalize those stem cells so they'll grow forever and ever and ever. And as Henry said, we'll fill up the casino room. You can expose them to exotic growth factors. Or you can do things that mimic what normally happens with those stem cells in the body. So again, on our guidelines, obviously, short-term culture as well. Inserting genes wasn't going to work. The risk factors associated with that are pretty vast at this point. Long-term culture has been shown to induce some significant changes in the cells, at least when you're talking about pluripotent cells. Exotic growth factors, same types of things. There's some significant unknowns there. So for ICMS guidelines, it's short-term culture and physiologic changes to the cells in order to get to, again, being able to use stem cells much earlier. So if we look at the lab guidelines that we put together, I'm not going to reduce, this is a 50-page document, all of it, but I think just some general concepts would be helpful. Obviously, as Henry talked about, you can have a lab where many of these things are done. The closest analog for physicians would be fertility labs. Fertility labs, as you know, pretty much every fertility specialist these days has an IVF lab. These are credentialed through the CAP program, the College of American Pathologists. They're doing culture expansion. A 3 to 5 day blastocyst culture is 100x, so that's become a very common procedure these days in fertility labs. These are not FDA-regulated biologic drugs, obviously. This is the practice of medicine in any given state that you find a fertility lab. So this is probably the closest analog to a stem cell lab. If we look at stem cell lab guidelines, we have put together a third party to do accreditation of stem cell labs. That's a company called Registry. They're a nationally known company that does this kind of work for accreditation. The lab guidelines that we've put together are similar to CGTP, or current good tissue practice. The focus is on an autologous tissue culture lab, not on a production facility. And there's a minimal culture expansion is the goal.